it's my pleasure to introduce our speaker for Grand Rounds this afternoon. So Dr. Adrian Vella is a professor of medicine at Mayo Clinic in Rochester. He completed his training at Mayo Clinic through the Clinician Investigator Training Track and subsequently spent 2 years as the Mayo Foundation Scholar at the Cambridge Institute of Medical Research in the UK. His clinical interests include the diagnosis and management of hypoglycemic disorders. In addition, he directs a program funded by the National Institute of Health that's aimed at understanding the pathogenesis of prediabetes and factors affecting islet function. So today he'll be speaking about the diagnosis and management of hypoglycemic disorders.
Thank you very much, Catherine. Thank you for having me. It's a pleasure to be here. I've had a very enjoyable day. And I hope you'll enjoy my talk now. So I'm going to talk about what I consider my clinical hobby. Okay? Hypoglycemic disorders can actually be very satisfying. I'm serious. Because can be, I said. It's not always. But when the highs are high and the lows are low. Okay? And then I always show this photo. Anybody knows what this is? This is the arch in St. Louis, taken from a very unusual perspective. Okay? So it's my way of saying this is my perspective on hypoglycemic disorders. Okay? Fair? I've actually consulted quite a bit for companies both inside and outside the hypoglycemia space. But really, nothing's relevant to what I'm going to be talking about today. So I'll start at the very beginning with this quote from an editorial written in JAMA in 1924 by a gastroenterologist by the name of Seal Harris. And he was the first person to put in writing, at least as far as we can ascertain, the idea that people were having symptoms suggestive of hypoglycemia, but not taking insulin. Remember, this is 1924, so it's about 2 years after insulin is discovered and beginning to be used, and hypoglycemia documented in people with type 1 diabetes being given insulin. And he was saying, look, I see the same symptoms in people who are not taking insulin, so could it be that there's a condition called hyperinsulinism? I should acknowledge, actually, that this comes from the research that Dr. Service did some time ago. I'll be acknowledging him later, but Dr. Service's interest in insulinoma is also in part because of this case. So in the past, history records at Mayo used to be in a packet, and there'd be a face page outside the packet. Do you remember the packets? Have you seen? You've seen the packets?
For research.
Yeah, exactly. So that'd be the patient's name, okay, with the first time they come, they'll have the initial diagnosis. So this is from December 12th, I'm sorry, 1st December 1926, okay? It's a doctor, he's an orthopedic surgeon from Miller, South Dakota. And if you can see here, the surgeon is Dr. William Mayo, okay? And the poor man actually was having symptoms of hypoglycemia. He was passing out in the OR. People were actually feeding him to keep him going during surgeries, okay? He came to Mayo for evaluation, and he was actually found to have what they called a carcinoma of the islands of the pancreas, okay? He had an islet cell tumor, which was widely metastatic, and extracts from this tumor actually caused hypoglycemia in a rabbit, okay? So, so this was the first description. The clinician involved was Dr. Wilder, who actually went on to lead the NIH for a period of time, and who actually came up with the idea of clinical research units, basically. So he had multiple contributions. The other thing about Russ Wilder is that when Banting and Best actually had the discovery of insulin, the three eminent diabetologists that they invited to Toronto, there was Elliot Joslin, and Russ Wilder was one of the three. I'm blanking on who the third one was. But anyway, so he was already quite well known in the field of diabetes. Again, this is all thanks to John Service. So that's 1926, okay? But in 1934, sorry, I did not mean to do that. In 1934, okay, this is proceedings of the staff meetings of the Mayo Clinic, which today is the Mayo Clinic proceedings, okay? One of the endocrinologists is already talking about hyperinsulinism, misuse of the term, and he's talking about functional hypoglycemia. So even within 6 years of the description of a new disorder, okay, they're already recognizing that there are people who have symptoms but no real disease, okay? I'm sure that's familiar to all of you. So this led to the application of Koch's postulates, so to speak, to the diagnosis of hypoglycemia. So Whipple's triad says you have to have a low glucose, okay? Now over here I've written 50. That's not completely true, okay? The asterisk is there to remind me that the value isn't necessarily a hard and fast value, but also that it's got to be a venous blood, okay? CGM and fingerstick do not count, okay? At the time of the low glucose, the patient has to have neuroglycopenic symptoms, okay? Adrenergic symptoms are less specific. So racing heart, sweatiness, tremor, tachycardia. Okay, interesting, but they could be a panic attack, right? If you can't subtract 7 serially from 100, some people can't do it anyway. but anyway, but if there is evidence of cognitive dysfunction, okay, that is quite strong in favor of a hypoglycemic disorder. And correcting the hypoglycemia corrects the symptoms. Then, essentially, if you have fulfilled those 3 things, then you have a hunting license. You can go work out what the pathogenesis is and perhaps go looking for an insulinoma, okay? If you haven't fulfilled those 3 things, you're building a house on sand, okay? And that's bad territory to be in. Now, Dr. Kohn in endocrine circles is revered because he described primary aldosteronism, okay? But in hypoglycemia circles, we're not so happy with him because he came up with the idea of reactive hypoglycemia and using an OGTT as a test for people with hypoglycemia symptoms. The problem with that is that if you take a population, okay, a general population, especially the younger and leaner you are, the incidence of a low glucose after a 75-gram OGTT increases. So in a general population of all comers, it can be as high as 20% that people have a glucose below 50, okay, sometime after a glucose challenge. So an oral glucose challenge should have no role to play in the diagnosis of hypoglycemic disorders, okay? But he codified this idea of reactive hypoglycemia. And of course, there was an epidemic of this. I wasn't around in the 50s, but John Service used to assure me that it was quite fashionable that people had the diagnosis of reactive hypoglycemia. And essentially what it came down to was the occurrence of autonomic symptoms in the postprandial period, okay? Whipple's triad was never clearly fulfilled. And a lot of people with reactive hypoglycemia often had other non-organic illnesses. Today, I'm sure we recognize POTS and fibromyalgia amongst the frequent passengers on the same ship, okay? And in fact, John Service felt strongly enough that he studied 33 patients, and on one occasion they got an OGTT, on the other occasion they got a mixed meal, and EEG recording during the challenges, okay? And he showed that their symptoms were independent of the glucose nadir, and there were no changes on EEG monitoring, okay? And no associated autonomic symptoms to support a diagnosis of hypoglycemia with the oral glucose challenge, okay? So don't do an oral glucose tolerance test, okay? Timing of symptoms isn't really very helpful for the diagnosis, for the underlying etiology in terms of giving you clues as to the underlying etiology. It's helpful to us when we're trying to decide what test to do next, okay? But in practice, so this was Kim Plakowski, as she was then, was from Milwaukee. She went to medical school here, now that I think about it. But when we looked at the at our 25-year retrospective experience in 2009, about 25% of patients with an insulinoma had postprandial symptoms. In a few cases, exclusively postprandial symptoms, but certainly it doesn't tell you much about insulinoma. Sometimes patients have difficulty telling you whether they're having symptoms in the postprandial period or the fasting period, okay? So, what are the criteria for endogenous hyperinsulinemic hypoglycemia? So we already said that your glucose needs to be low, okay? It probably should be lower than 55. Why is that? Well, Phil Cryer a long time ago showed that endogenous insulin secretion stops at around the 60 milligram per deciliter range, okay? So you want to be in a situation where you shouldn't be expecting endogenous insulin secretion, and the glucose is low. So that's where the 55 comes from, okay? And these are the criteria that are, to this day, still in the Endocrine Society guidance for hypoglycemia, okay? Now, it's important to understand a couple of things. Number one, the guidelines were published, I believe, in 2008 or 2009. Since then, immunoassays have become more sensitive, okay? So they can detect lower and lower concentrations of beta cell polypeptides, okay? So detectability by itself doesn't necessarily mean abnormality, okay? And we already knew then, as I'll show you in a second, but it means that the surrogates for insulin, okay, have become more important and more specific in making a diagnosis of hyperinsulinemic hypoglycemia. The other point to make is that this came from the 72-hour fast database Dr. Service had developed, okay? It's for fasting. It's for situations where a patient is basically having blood sugars fall lower and lower and lower over a period of time, okay? Why is that important? It's important because in the postprandial period where you secrete insulin anyway, there's time necessary to clear all these beta cell polypeptides. And while insulin has a half-life in minutes, 3 to 5 minutes, okay, depending, C-peptide and proinsulin have a half-life of about 30 to 35 minutes, okay? So to clear 5 half-lives, we're talking about 2.5 hours, okay? So again, detectability in the postprandial period doesn't necessarily mean that you have endogenous hyperinsulinemic hypoglycemia. Oh, sorry. And before you say, oh, okay, we have an insulinoma on our hands, it's very important to ensure that you have a sulfonylurea screen, which is negative, okay? So this is Kim's retrospective review, okay? And at that time, this is 2009, we looked at sensitivity and specificity. And even then, the response to glucagon and the presence or absence of beta-hydroxybutyrate were more specific insulin bioassays, okay, for the diagnosis of insulinoma, endogenous hyperinsulinemia, than the measurement of C-peptide, proinsulin, etc. Beta-hydroxybutyrate is a ketone, okay? It's a breakdown product of fat. Its production is going to be inhibited by insulin. So typically in hypoglycemia with an insulinoma, you do not have a rise, during a fast, you will not have a rise in beta-hydroxybutyrate. And when somebody has a glucose of 55 or lower, there should not be any glycogen reserves in the liver, okay? The only way you have glycogen reserves in the liver is if you have abnormal insulin secretion protecting those glycogen reserves, okay? So if you have a delta of glucose in response to glucagon of greater than 25, that's abnormal, okay? And that's indicative of an insulinoma. So that's one part, okay? The second part, so the first take-home message, I think, is do not use an OGTT, okay? Perhaps the second take-home message is do not use finger stick. The third take-home message is if somebody comes to the clinic telling you that they have hypoglycemia, please, please do not prescribe a CGM. It will make their life miserable. It will make yours even more miserable. And ultimately, it might make my life miserable too, okay? So nowadays, Dr. Shah and myself refer to this as dexcomitis, okay? Because we could spend at least a day a week just seeing patients who think they have hypoglycemia because somebody's prescribed them a CGM, okay? CGMs have multiple vagaries. It's important to remember that during the night, especially young, lean people, or people after bariatric surgery, by the way, will often have blood sugars in the 60s and 70s. That's a range of glucose where the sensor isn't particularly good. They're not very good at the low end. So frequent asymptomatic nocturnal hypoglycemia is almost a given, okay? And the other thing to point out, this is from 2019, okay? When healthy individuals wore a sensor, okay, 28% had at least one event where the glucose was below 55 for a significant period of time, okay? This is part of the water, okay? So it's very easy to get people to believe that they have hypoglycemia if they feel tachycardia, tremor, etc., etc.
I'll wait up here. I'm supposed to do it up.
There's somebody who's
I'm coming back.
Good. Wow.
This isn't a dog barking.
Good.
Anyway, so again, perhaps I hope I've convinced you, although I know this is a sophisticated audience, but CGMs for undefined symptoms are a bad idea. Okay? Now, I'm going to walk through cases, okay, with examples. On Saturday, when I did more or less this presentation at the ACP meeting in San Francisco, I confused the audience with case 2 and case 3 for a second. So I'll take some time when I get to case 2 and 3, okay? But the first case, okay, if we go through the biochemistry, low glucose, okay, very high insulin, low to suppressed C-peptide proinsulin, suppressed beta-hydroxybutyrate, but a positive response to glucagon and a negative OHA screen, okay? So this particular example was a 41-year-old female who comes to clinic with a 2-year history of hypoglycemia. No upper GI surgery, a question that is always important in my opinion, okay? The remainder of her medical history is unremarkable. And this was her profile, okay? So if you look at the timeline, at 8:30 when she walked into the endocrine testing center, her glucose was 96. At 10:30 it was 75. nothing very unusual at that point in time. But between 10:30 and 11:05, when she developed symptoms, her glucose had fallen to 53. And you can see that insulin was a bit wishy-washy, okay? C-peptide not quite suppressed, proinsulin not really suppressed, okay? But ketones are suppressed, okay? This is the modern presentation of what 10 years ago would have been this, okay? Sky-high insulin, C-peptide and proinsulin completely undetectable, okay? This patient was taking aspart, as I'll tell you in just a second, okay? And this was not the particular case in which it happened. This happened in the supervised fast in the endocrine testing center. But the very first patient we saw like this actually left my office and the desk staff saw her inject insulin, okay? And we obtained an urgent bundle at that point in time, and insulin was not detected because the conventional insulin assays do not actually always detect analogs. So in the beginning, if anybody had dealings with Mayo Medical Labs 10 years ago, and you were suspicious of exogenous insulin, they'd run a panel of assays, of immunoassays, with variable specificity. One works for aspart, the other one works for Humalog, okay? Now we're doing, as I will show you, a mass spec assay, which will tell us what it actually is. But the other point to make is that in this patient, again, with a short-acting insulin that you give acutely, you may not have time to suppress your beta polypeptides completely. Okay, so they might still be detectable. So the pharmacokinetics and pharmacodynamics have changed a little bit compared to what we knew about insulin in the past. Okay, so keep that in mind. And in this case, I told you that. In this case, there was one key issue. Her boyfriend was using an insulin pump. Okay? She was lost to follow-up. And this is a good time to tell you that the prognosis of these patients is actually bad. Their 5-year mortality can be as high as 50%. There aren't very good studies because thankfully the case series are small. But always, if you ever come across somebody who's injecting insulin to cause hypoglycemia, it's usually a very bad sign, okay? And they may die of insulin-mediated hypoglycemia or they may die of other causes, but they have a 50% mortality, okay? So keep that in mind. And the other point is that a concentration is not equal to secretion because of what I told you about clearance, okay? And half-lives. Always keep that in mind. Okay, now, case 2 and case 3, okay? In reality, I'm not going to show you a case 2. I'm going to show you 2 cases of case 3, okay? Bless you. Because at the end, I got asked, why did the patient with insulinoma have a positive sulfonylurea screen? No, that's not what I'm going to show you, okay? What I'm trying to say is that people with a biochemical picture that is typical of an insulinoma, okay, differ from people who are taking a sulfonylurea only in whether they're positive or negative on the sulfonylurea screen, okay? That's the point I'm trying to make here. So these people have normal or inappropriately normal, or they may have high insulin, C-peptide, or proinsulin. A high proinsulin has sometimes been used as a marker of aggressiveness or malignancy or size of the tumor. And yeah, it's probably true, okay? I once had a patient present with a proinsulin that was greater than the upper limit of detectability and very mild symptoms. It was a malignant insulinoma, okay? And in the literature, that is supported, okay? And the surrogates of insulin are all compatible with insulin or an insulin-like substance being present. So the first case I'm going to show you is reasonably straightforward, okay? 25-year-old, 8-month history of episodic dysarthria and confusion. He had 1 car accident, 2 seizures, told he had epilepsy, no upper GI surgery. And he's scheduled to see me at 8 in the morning. In the evening, he's taken to the emergency room, and his glucose is 55. Insulin is high. Proinsulin is quite high. Okay. And beta hydroxybutyrate is suppressed for a glucose of 55, and sulfonylurea screen is negative. And this gentleman, this was an easy case. Okay, by noon the following morning, we had a diagnosis. Okay, and he saw the surgeon a couple of days later and got it resected. Okay, so that's a typical insulinoma, and you can see that it's relatively hypervascular compared to the surrounding pancreas. Okay, this is a typical insulinoma. It's not this patient's insulinoma. The tail, as you can see, of the pancreas, and you can see that there's this hard, relatively fibrous tumor compared to the surrounding fleshy pancreas, normal pancreas. Okay? This one was one of the more challenging patients. Okay? So 44-year-old college professor, 1-year history of episodes, and she had significant confusion. Okay? Low glucose recognized on multiple occasions, and she had multiple imaging studies. Okay, father's a retired radiologist, all negative. Okay, all negative. So she comes to us, and we do a calcium stimulation test. Now, I don't know how familiar or not you are with the mechanics of a calcium stimulation test, but the pancreas, at least 80% of the time, is supplied, the head is supplied by the gastroduodenal artery. Most of the body and tail are supplied by the splenic artery. And then a variable middle portion is supplied by the superior mesenteric artery. And basically the radiologist will cannulate each artery in turn, inject calcium, and a catheter in the hepatic vein is used to measure the insulin response, okay? And when John Dopman first characterized it, he said, you know, a 2-fold rise or higher is abnormal. In this particular example that I'm showing you, this was a case where somebody had an insulinoma in the uncinate process, so the watershed of the gastroduodenal artery and the superior mesenteric artery. That's why he had a response in those two territories. And about 15% of the time you'll get lucky and you basically have a vascular blush during the angiogram phase of the calcium stimulation test, okay? That's very helpful, of course. My patient had a positive response in the gastroduodenal artery, a very positive response, not 2-fold. 2-fold is probably not correct nowadays. When Dopman described it, he was using old insulin assays, okay? Nowadays, probably you need at least a 4 to 5-fold response. As we'll show you, most insulinomas have a 7-fold response or higher, okay? And this would certainly be compatible with that, okay? But the patient had a positive response in the gastroduodenal artery and the splenic artery. Rather strange, okay? And it turns out that we actually had a visible blush, okay? The problem was that there was a communicating artery from the gastroduodenal anastomosing to the splenic artery, and I don't think I have the cuts. No, I don't have the cuts that we want, okay? But the point is that it's easy to say you can do a calcium stimulation test, but you really depend on the radiologist and their ability to pick up aberrant circulation, okay? Because this lady, we delayed surgery by about 6 months because we weren't confident of the first initial calcium stimulation test. Okay, we ended up doing a second one. And then we actually saw the communicating artery much better. With hindsight, we went back and saw it on the first one. Hindsight is always better. But there you go, okay? So that's case 3, 2 cases of case 3. Okay, what does case 4 have for us? Case 4 is a patient with low glucose pretty high insulin and variable proinsulin and C-peptide. Again, surrogates for insulin or insulin-like factor are positive. This patient had both fasting and postprandial symptoms. Okay? Documented neuroglycopenia on several occasions, imaging negative, referred for further workup. So this is obtained at the time that she had symptoms and a glucose of 36, and you can see that there's a very generous insulin, very, very generous C-peptide, very generous proinsulin, okay? When you see numbers like that, either somebody has a very aggressive metastatic insulinoma, okay, but imaging is negative, or they have insulin antibodies, okay? When you see industrial strength beta cell polypeptides, that's what it's probably going to be, okay? And unfortunately, our lab nowadays has become very reluctant to do this. But really what you need to do is you need to test for the binding capacity of these antibodies. So not only should they have antibodies, but you need to prove that they actually have a capacity for binding and holding insulin, okay? And that usually involves using radiolabeled insulin. So it's a bit of a messy test, but that's really what you need to do, okay? This patient had mixed connective tissue disease and actually had been given rituximab sometime before for the mixed connective tissue disease. There are several case reports now of rituximab being used to treat antibody-mediated hypoglycemia. In fact, we've just done it in a patient a couple of times very recently. And it certainly will decrease the titer of the antibodies, and symptoms seem to correlate with that. Okay, case 5. So case 5 has a low glucose, but suppressed polypeptides. Okay, no evidence of insulin. Beta hydroxybutyrate is suppressed, and there is a positive response to glucagon. So, in the absence of detectable exogenous insulin, this implies that the patient is making an insulin-like factor, okay, which is causing hypoglycemia. So, this is a 73-year-old who I saw in November of 2024. She had poor appetite and had a 6-pound weight loss and was complaining of early satiety, okay? She had significant abdominal bloating, and somebody had given her a CGM, okay, which was alarming constantly. And she was seen elsewhere by somebody who I respect a lot, okay, and was told, this is starvation hypoglycemia, okay, you need to increase your eating, okay? And this went on for a couple of months, and then somehow she ended up on my calendar, okay? So these are the results from the outpatient fast, okay? In reality, she only fasted for about 2 hours. Glucose of 58, undetectable insulin, really low C-peptide, low proinsulin, suppressed beta-hydroxybutyrate, negative sulfonylurea screen, really big response to glucagon, okay? Now, by the time we did the fast, we already had the diagnosis. The diagnosis could be made by looking at her tummy, okay? But it's more impressive to show a CT scan. So that's cross-section, okay? Hey, what is this? This is abnormal, I think, right? It's not supposed to be there. It's quite big. In fact, you could see it. You literally could see it, okay? So she had a solitary fibrous tumor. These are the sort of mesenchymal tumors that are associated with this condition, okay? Tumor-mediated non-insulinoma hypoglycemia. So these tumors make an insulin-like factor, a lot of people, there's been a lot of literature dedicated to saying it's an IGF-2 mediated process, okay? Don't care, not necessary to make the diagnosis, okay? It's certainly an insulin-like factor, and she was lucky because it was resectable, okay, in its entirety, and so far, touch wood, she's been completely symptom-free, okay? So here's my other plea to you, okay? Don't see somebody, okay, who has hypoglycemia and measure an IGF-2, because it can lead you down the garden path. And I've seen people who have had IGF-2s measured, imaging is negative, so and then they do PETs, they do all sorts of things, okay? And everybody's confused and worried at the end of it. Usually, tumor-mediated hypoglycemia is caused by a tumor that you know about and is easy to find, okay? It's not going to be some occult little thing in your thyroid or in your pituitary or wherever. It has been, thymus was another one that I was sent, okay? It's very, very rare that you have an occult tumor presenting. This, in a sense, hypoglycemia was the presentation. But with hindsight, it was there under our noses, okay? Okay, last case. So, sorry, the last case, the biochemistry is similar, okay? At least a table that you might get on a board exam. The presentation is similar, okay? So, 30-year-old post-cesarean section, her sister-in-law goes to visit her, and she's unarousable. She wasn't acting. It's not because she didn't want to talk to her sister-in-law, okay? Her blood glucose was 36. And she was given IV dextrose, and she improved. And they screened her for sulfonylureas, and it was negative. They didn't believe it. They repeated it. It was still negative. They repeated it a third time. It was still negative. So they sent her to us, okay? Oh, yeah, they did the CT of the abdomen, which was negative, okay? So nothing very dramatic on physical exam, okay? And again, I mean, she had a glucose of 41. I think it was about 12 hours into the fast. She had neuroglycopenia at the time. At least I was assured by the fellow responsible that she had neuroglycopenia when he stopped the fast, okay? And she had a flat response to glucagon, okay? So this is not insulin mediated. This is extremely uncommon. Again, in this case, I was lucky. I knew the answer. I already knew she had a low cortisol and a low HTTH. We were doing this just to prove that that was the likely mechanism, okay? She had lymphocytic hypophysitis. It was a presentation of lymphocytic hypophysitis. And in adults, it is extremely rare to have low cortisol present with hypoglycemia. In children, it's common. With growth hormone deficiency, it's common in children. Adults, very rare, okay? So at that time, and I know it's very rare, you know how I know? Because at the time, to go to Endocrine Society with a case report, fellows needed to have at least 3 cases, okay, of the same syndrome. They had to have a case series, okay? And so this fellow was very keen to go on a trip to Endocrine Society. So he did a search of the Mayo database. He found 2, okay, 2 adults with hypoglycemia in the setting of adrenal insufficiency. So it's uncommon, okay? But it can happen. So think about it, okay? All right. I was made to promise during my meetings today that I would talk about post-Roux-en-Y gastric bypass or other upper GI procedures about hypoglycemia, okay? And this, unfortunately, my institution has contributed to some of the confusion associated with this condition, okay? So, you have to understand it in the context of when this was published in 2005, okay? About 5 years before, John Service had published a case series in JCEM of, I think it was 9 patients, six or 9 patients. And he called this condition NIFS, okay, non-insulinoma pancreatogenous hypersecretion syndrome, quite a mouthful, okay? These were people who had exclusively postprandial hypoglycemia. They had a negative fast and a positive response to a meal, okay? And imaging was negative, okay? And they had an abnormal calcium stimulation test. And those people did not really have a history of upper GI procedures, okay? I think there may have been 1 or 2 in that cohort. But it's true, there are some people who have that condition that is different from this condition, okay? And so they get conflated all the time, okay? This supposedly is the hallmark of another word that I don't like using, nesidioblastosis, okay, which is the proliferation of small islet precursors from ducts. The problem is, there are 2 problems with it. One is that in autopsies of asymptomatic patients, you come across this morphology all the time. So as a pathologic entity, it is meaningless, probably. The second is that pathologists have no standard criteria for making the diagnosis, okay? So 2 pathologists could be looking at the same tissue and disagree as to the presence or absence of nesidioblastosis. So that's part of the problem. But at the time, okay, these people post-gastric bypass were being seen. They were being told to eat a meal that causes their symptoms, that provokes their symptoms. So I'd walk into the endocrine testing center, and there'd be people post-Roux-en-Y gastric bypass eating pancakes and maple syrup, okay, or ice cream, things that basically we know anybody who has had a Roux-en-Y gastric bypass will have a bad response to. Okay, so not really diagnostic. And then we'd send them to surgery based on the calcium stim test. And the problem is that 90% had symptom recurrence within a year or 2, okay? So not much benefit. So we stopped doing that, okay? The other thing is that the calcium stim test, okay, if you use the 3-fold criteria, you might actually get a positive response, okay, in some territories. But if you look at the absolutes compared to what I showed you for insulinoma, they're much lower, okay? And in fact, this was work done by Scott Thompson when he was still an MD PhD student, looking at our retrospective database, and he listed them all as nesidioblastosis versus insulinoma. You have to understand that this is a log scale, basically. But what he showed was that, you know, the absolute needed to be for the absolute insulin value needed to be substantial, greater than 80, to be diagnostic of an insulinoma. And typically the response, okay, was greater than 7-fold, almost 8-fold in an insulinoma, okay? So we no longer, when we see people post-Roux-en-Y gastric bypass, we no longer do calcium stim tests. We no longer send them to surgery for extended distal pancreatectomy, okay? Most of the time, the first mainstay of therapy, and I'm sure we'll talk about this in question time, is dietary modification. Sometimes we use things like acarbose, which may be a glorified placebo. And then in the refractory cases, I tend to use short-acting octreotide most of the time. But it's my bias. All right. So taking care of patients with hypoglycemia is straightforward if you fulfill Whipple's triad. Okay? Everything else hinges on that. Without Whipple's triad, you're building a castle on sand. It's important to emphasize that fingerstick, CGM, and OGTT do not count. And I'm a little leery of using caloric liquids. Okay, so when we do the mixed meal test, I don't let people drink orange juice. Okay, as part of the challenge, because again, like an OGTT, who knows what will happen. So I try to avoid caloric liquids. I'll conclude by acknowledging John Service, who was my clinical mentor. Okay. Unfortunately, John passed away in 2020, and he knew more about insulinoma than I ever knew, or that he taught. Well, it wasn't his fault. He tried to teach me. I just didn't learn. But there you go. So anyway, thank you very much for listening to me. I'll be happy to take questions as they come in. Okay? Yeah.
I have lots of questions, but I'll stick to one or two. So, fantastic talk. Thank you so much. Do you see, so we get most of the inpatient consults as end-stage liver disease or end-stage renal disease, kind of lowish blood sugars, they never quite get there.
Yes.
What are your comments on that? What do you do for them?
So I apologize because I used to include a part about hypoglycemia in the hospital, in hospitalized patients. And John used to say that you get more out of looking at the med list than in examining the patient. Which is true, because obviously iatrogenic causes or medication interacting with disease, like dextropropoxyphene, for example, was a common cause of hypoglycemia in people with end-stage renal disease. Now, dextropropoxyphene is no longer available as an analgesic, but that used to be a common one. Okay. Most of the time, number one, recognizing it. Number two, informing everybody concerned that that is usually a poor prognostic sign. Many a time it's just a question of nutrition. It's the best you can do, but not a very satisfying answer. I'm sorry.
Yeah, I mean, so that's the state of it. So never get an answer, and then you just kind of discharge them. One other question. So there are some type 1 diabetes patients that I don't know if any of our diabetes team is on, but there's often there are these 2 units, especially in the setting of end-stage renal disease. And just recently there was a patient who received 2 units of insulin about 3 days ago, still hasn't gone into DKA. And believe it or not, we did the C-peptide, and the patient had detectable C-peptide. Not much, but somewhat, suggesting that there was some insulin production. That's why the patient never went into. But this confusion, well, the patient has had type 1 diabetes for several years, but now that it's not quite as type 1.
But remember, it's clearance as well. So in renal failure, insulinoma is really difficult to diagnose because it's very difficult to suppress beta cell polypeptides. And in fact, when Pankaj was a fellow, I think he and John published 2 people with end-stage renal disease who it turned out had an insulinoma. And they actually did a calcium stim test to make the diagnosis, because then at least you have the delta. You're starting out with a high baseline, but there's a delta. So there's that part kind of thing. What was it you that I was telling about my type 1 patient who used to come back?
So
he had an insulinoma?
This. How long do you have? So is there, like, assuming this patient really did have maybe.
Oh, I see what. Yeah, I can answer
I'm
that
not
actually.
thinking this one is insulinoma, but patient had some.
I can answer that actually. Okay. So DCT, published about 4 years ago. 30% of the cohort. So we're talking now 40 years since they entered. They still have detectable C-peptide. Now, detectable doesn't mean high C-peptide. They had detectable.
Okay.
But so it grumbles along for a long time.
So does that explain if you have end-stage renal disease, then there's a little bit of C-peptide, and then because
I would tend to think so.
We sent this patient home on 2 units every 48 hours or 72 hours, like literally not an answer. But
Basically, what it want him to have an insulin which is given once a week normally?
I don't know. I mean, we would just kind of, check your sugars. If it's so over this, call us. But it was
Yeah.
kind of
Yeah.
difficult to send a patient who has been lifelong insulin to come home without.
Without any insulin. Yeah.
Yeah. That's it.
There is a question from online, Dr. Vella. So it says, in Asian patients with carotid disease,
Yeah. Right. Yeah.
are there different antibodies encountered?
No, the antibodies are the same. Usually, when Hirata first described the syndrome, it was basically associated with PTU use in people with Graves' disease. And in those cases, stopping the PTU actually made things better. But the antibodies tended to be the same. John Service actually went through life thinking he was never going to see a case. And then the first 2 cases he saw when I was a fellow. And then all of a sudden, there were like 6 patients. And I think he and Andy Basu published like 6 Caucasian patients with antibody-mediated hypoglycemia. I think it was endocrine practice at the time. Since then, so I've seen the very first one that I saw by myself wasn't one of those original 6. He actually turned out to have a multiple myeloma. He had a monoclonal spike, and he had a smoldering multiple myeloma as part of the presentation. He did well with rituximab as well. But it's uncommon. I mean, I think I've seen 5 new cases, maybe a bit more, but it's not common.
I have a question online.
Sure. Whoever, don't fight. I'm here for as long as you want me to.
Go ahead, Abubakar.
My question, first, thank you for the very easy to follow approach. My question is on the glucagon response.
Yes.
That when discussing with other colleagues from outside our group, it does not seem to be as many people as doing it at the conclusion of the 72-hour fasting. So I just want to see if you have any comments in doing it, at the conclusion, even if, you don't have hypoglycemia.
So it's only helpful if it's only reliable, is perhaps a better word, is if the glucose is 55 or less, okay? But I think it's an important part of the workup because in a normal fast, it is possible to have a glucose of 50. You may not have the beta-hydroxybutyrate back, but if you have a flat response to glucagon, it's very reassuring that you likely have a normal fast on your hands. So I've tried to make it part of the practice. I didn't have to try. John had made it part of the practice for a 72-hour fast a long time before I ever walked into the building. But I think it's an important part to emphasize. Does that make sense? Did I answer your question?
Yes.
Okay, good.
So I mean, if you don't have a hypoglycemia glucose below 55, then it's not as helpful or reliable.
It's most of the time the increment is less than 25, but occasionally you will see an increment of greater than 25. But if the glucose was 70 to start with, probably is meaningless. If that helps.
Thank you.
Oh, sorry.
Yeah, thank you so much for the talk. I love your term, the dexcomitis. I was kind of curious, even though we won't be using, of course, CGMs for the diagnosis of hypoglycemia, are there certain cutoffs for lows and very lows that would make you more concerned about a patient having insulin-mediated hypoglycemia, or is it just too difficult to say?
It's too difficult to say. I think I would say I don't have much experience in using that. I mean, I always say, look, if somebody says they're having hypoglycemia every single day, and then they come to the clinic, and they hang around for 2 weeks, and you never document hypoglycemia, I think you already have an answer, right? So usually with hypoglycemic disorders, it's usually easy to capture a low venous glucose. I'm speaking in generalities here, but I mean, I said something along these lines to somebody who, but when we were residents, John would call us and say, I'm admitting somebody for a 72-hour fast, this is going to be positive, or this is going to be negative. And I used to say, how does he know? How does he know? But having done it myself now, I'm like, yeah. Within 15 minutes, you can get a good sense of whether it is like, I mean, you do occasionally get surprises. That's why we do tests after all. That, you know, somebody you wouldn't expect to be positive turns out to be positive. But yeah, I don't really have insights. Also remember that, you know, they float from one sensor to another as well, where the baseline sits. So
I think that article from Viralsha, they had CGMs on normals, and they did have some normal like patients without anything.
Yeah.
In 30s. So
yeah.
So there's like 1% or something. So yeah, there is no actual cutoff. That's the good.
Thank you. So, how much success have you had with octreotide for this post-variant hypoglycemia? I have not.
Really? So what do you start? What dose do you start?
50.
Yeah, I would start with 50. Sometimes I go down rather than up.
Okay.
So I think I said that there's a phase 3 study that just completed using an octreotide-like drug, which is going to be interesting. But it's really interesting because it reinforces my my prejudices that this is more dumping physiology than it is low glucose as a cause of the symptoms. And obviously, you know, blocking the GLP-1 receptor or giving glucagon at 120 minutes after a meal is only going to treat glucose. It's not going to do anything for the vascular changes, the tachycardia, the hemoconcentration, the low blood pressure that occurs with dumping physiology. And somatostatin analogs are really the only things we have right now that will actually address those. So that is one caveat. The second caveat is that ultimately, unfortunately, the only test we have for following patients clinically is, are you better on the medication or not? And that's very variable and of course very unscientific. I think there are hard endpoints that you can measure for therapeutic efficacy, like for example, hematocrit dilution, hemoconcentration that occurs 30 minutes after meal ingestion as a marker of dumping, or you could measure blood pressure change during a meal test as an objective measurement of whether it's at least fulfilling that. I would say that the majority of patients that have started it on, it's certainly they say they feel better. Does it take away things? No, not completely. I mean, I always tell patients I can't cure, but if we go from 7x to 1x, whatever x is, then we'd consider that a victory.
Would you ever give CGM in that setting?
Most of the time, by the time I see them, they are on CGM. Sometimes I don't interfere. Okay, sometimes, especially when I get the feeling that what I will tell them is, for God's sake, ignore whatever happens at night, okay? Because very often it will alarm at night. I say, if you're having true hypoglycemia at night, we rip up the diagnosis and start all over. Okay? But a lot of the time I tell people to not use the CGM if it's taking over their life and causing anxiety. What I do say is, with this condition, there's a variable period of time after you eat. 2 hours, 2.5, 3 hours, that you're at risk. So don't go getting into a car and driving at that time. If you want to use a CGM for those periods, that's fine. But I struggle with that question. So if people are passing out unexpectedly, I rarely tell them to stop using the CGM. But most of the circumstances I tend to.
There's just one more question online.
Yeah.
So it's from Dr. Shaker. He says, great talk. How bad does starvation have to be to cause hypoglycemia? Is it a sign of imminent death?
It can be, actually. So I personally, thankfully, have never seen it. But it's usually very bad cases of anorexia nervosa. And hypoglycemia is recognized as part of refeeding that occurs after starvation. So there is a possibility of hypoglycemia after people get treated for anorexia. The first time it was described, does anybody know when it was first described? Hypoglycemia after refeeding?
Holocaust, World War II.
Exactly, May 1945. The concentration camps, where people actually died because they were fed. But that is the sort of starvation we're talking about, where you would have hypoglycemia.
Would you treat post-bariatric patients with GSI?
Oh, yeah, absolutely. I mean, it's difficult. We were saying 10 years ago, there was a high incidence of people you'd see in the clinic with post-bariatric hypoglycemia who had only seen the bariatric surgeon prior to bariatric surgery. They had never seen a dietitian. They never knew what diet to follow, etc., etc. Those you get huge mileage with dietary manipulation because they're seeing a bariatric dietitian for the first time. That scenario has become less and less and less likely now. But most of the time, again, this was another conversation we had with somebody else, which is what meal do you choose for the diagnostic test? Do you choose a bad meal or do you choose a good meal? I choose a good meal. You could make a case of having a patient do 2 tests, bad meal, good meal, but then that's a bit unfair. Who wants to foot a bill twice? Okay. So if they have the Vella standard meal, okay, most of the time they pass. They don't have hypoglycemia. So I say, okay, what this means is that if you had this meal 3 times a day, the likelihood is that your symptom frequency will fall. Won't go away, but it will fall. So do you want to try 3 months of diet before we consider octreotide? That's usually my modus operandi. But nowadays we certainly see people who... Now, the other thing, of course, is that there is a somatostatin analog which is available as an oral tablet. I haven't tried it yet. So, again, one of the new unpronounceable names, Paluzoleti, right?
Calcinify or something, yes.
Yeah, exactly. I haven't tried it. I'd be curious, actually, as to
What about the GLP-1 antagonist? I mean, that's kind of also floating around for a while now.
Yeah.
Nothing came up.
they're in a phase 3 trial.
Phase 3. Okay.
They're in a phase 3 trial. In fact, as I disclosed them on the Data Safety Monitoring Board. I mean, the data seems to say it's safe, which doesn't surprise me. We've used Extended 939 in our studies, in our research studies for a very long time, and nothing happens to them. No nausea, nothing. They never have it. Touch wood. Never have any adverse effects from Extended 939 infusion. But I think at the end, what it's going to show is that it will improve glucose